Your assistant is taking the bite, isn't it? But you are responsible. You need to ensure that yes, he has taken a good bite. Again, you are going to look for few things. You are going to look for few things. So when you are going to take a biopsy, first of all, take, again I told you this is wrong. If this is the scope tip, this is wrong. Remember I told you. All accessories should be out only this much, about a centimeter, beyond that. This is wrong to take a biopsy like this. Always the scope tip should be close to the target, whatever procedure you are doing. Whether it is sclerotherapy or banding or foreign body retrieval. Okay, this is it. This is the correct way. Now the biopsy forceps is out of the scope tip. You ask the assistant to open the jaws. The jaws are open. Under vision, now you are going to give the final push again. Okay? From the working channel, you are going to give the final push so that the jaws now are onto the tissue like this. Ask him to close. Close. Okay, he has closed. Then again, you are going to pull this now. He has closed this. Now again, you are going to hold it from the where it is entering into the biopsy channel and pull this out. Pull it. Now observe carefully. When I am pulling it out, see what is happening to the tissue. The tissue is getting tented. It is getting pulled here. It is getting tented. You see that? It is being pulled in this direction. You see this? This is the tenting of the tissue happening. This indicates that there is a good tissue bite. If it's just a superficial mucosal bite, this will not happen. This indicates a deep, full thickness bite. Full thickness doesn't mean full thickness of the wall. Full thickness means according to the depth of the biopsy jaws. Isn't it? If it's a superficial, it will be something close. It will be something like this. That's all. And it will just slip off like this. Open. So no tenting is off. Now close. Now you see this tenting happen. Open again. And you will have a good close. You should look for this tenting. Right before you pull this, you will see a tenting happening. This indicates a good bite. And you will know that yes, a good bite of biopsy has come.
We don't afraid from perforation when you do the like this.
Biopsy will never cause a perforation. Biopsy will never cause, until and unless it's a deep excavated lesion which has already eroded into the most of the layers of the, and now from the base you are going to take a biopsy. But we understand this, we never take a biopsy from the center of the lesion.
Yes.
We always take it from the margin. Right? Now see, this is what I am trying to explain here. First things first, scope tip should be closed so that only this much of the instrument is out. Then you go and grasp right here. Look for this mucosal tenting. You see this? This tenting of the mucosal tenting. All of you can see? This is what we mean by this. There and then you will know that a good bite has been taken. Okay? This is how it is. But this is all right here as long as the tissue is in front of you. What I mean is, you are in the stomach, you can move the tip of the scope, angulate it in whatever position the target is. Okay? But there are different scenarios, like if you have to take a biopsy from a flat lesion in the esophagus. Typical example would be Barrett's. Now the region is flat. It's a mucosal biopsy, but the lumen is like this, and this is the end viewing scope. So this is a small narrow esophagus, and you have to take a biopsy from the side. See this. This is the lumen of the esophagus. The scope is going inside, the biopsy forceps is out, but the lesion is on the side wall, flat. It is not protruding. So how are you going to angulate it and take a biopsy? I can simply tell you, to angulate the scope tip like this. Where is the space? The normal diameter is how much? What's the normal diameter of a esophagus? Small dimension which you should be aware of. 2.5 on an average. Obviously it's a distendable organ, but a normal without excessive distension over there is 2.5. So in that small area, how can you angulate, because this wire is also out? How are you going to take a biopsy from the side wall? How are you going to take a biopsy for a balance? So you modify your technique slightly. What you are going to do here is this. See, as long as it is stomach, you can angulate. There is enough space. And you can bring that target right in front of the biopsy forceps. But now the lesion is here. This is esophagus. The lesion is here. How will you angulate it in this way? So we do a slightly modified technique. The first is this. If this is my scope tip, so I am asking you to push only this much instrument. But even this is occupying some distance. This is occupying some space. So first things first, I will withdraw this much in. Okay? But making sure my jaws are out. So I'll ask my assistant to first open the biopsy course. Jaws are open and now I pull it back. Like this. So that now the jaws are resting right on the tip. Yeah? I have done away with this much of distance. I have occluded this much of dead space. Now the jaws are right here. Okay? And if I have to take a biopsy from here, I may still find it difficult to angulate it like this. So to take a bite from here, what will I do? I'll step back. You understand? The farther away I am, lesser would be my angle of angulation. You understand this point? See this. Here's the marker. Supposing if this is, this is the same concept which they use to launch satellites also. So supposing I have to go from here and touch this. This would be my angle. But if I am here, then my angle would be much smaller than this angle. You understand? So if I step back, I will have to angulate less. If I am right on top of this, I will have to angulate more. So I actually step back. So that with whatever little angulation I can do, so now I align my scope tip along the line of that target. Rather than sitting on the target or trying to bring it in front of me, which is not possible, I will take the biopsy forceps, open the jaws, and rather than trying to take a biopsy like this, which I cannot, I will step back here. Now I have that line, okay, in the correct alignment. So now if I push, it will come like this, negative. Okay, now I do. But another thing, last thing which you can do right here now is this. When you are ready to take a biopsy from here, at that last minute, apply suction. So draw it. The lumen collapses and that mucosa will now come in front of the biopsy and take a picture. Again, teamwork. Your assistant is going to take that bite, so you must train him that this is what you are supposed to do. Okay? So this is how you take biopsy from flat lesions which are lying on the side wall, not in front of you. This is what I have just explained to you. See, you step back from here. You step back. Rather than sitting on this, step back. And now you can do a little bit of angulation, which would be enough to give you this straight line. Okay? Now you are aligned along this. See, this much angulation is possible because you have stepped back. Okay? So that's the idea how you take lesion from here. Now a common question is, should I take a biopsy? How many biopsies to take? All those things are there. There is just a simple table to, because all lesions, some diagnoses are pretty straightforward. You don't even have to take a biopsy. So these are the guidelines. Esophageal candidiasis can be diagnosed directly on